adding 1 to 2 milligram of steroids or along with the azathioprine, and the patient is not responding. The third, or the academic or the clinical point, is the raised or persistently raised levels of the desmoglein 3, which we do not do in our clinical practice.
How long when do we call at a reconstruction if we are giving it 1 to 2 milligram of steroid, then it's not responding? How long?
आप 3 to 4 weeks तक देख रहे हैं और जब आपका पेशेंट नहीं रिस्पॉन्ड कर रहे हैं, नॉर्मली इट इज इन आवर प्रैक्टिस वी स्टार्ट विद 1 milligram, you go up to 2 milligram of those, and if it is not responding in 3 to 4 weeks, so it is a recalcitrant. उसका क्लिनिकल या एकेडमिक आप उसको पॉइंट ये कह सकते हैं, अगर हम उनके डेस्मोग्लाइन 3 लेवल्स करेंगे तो वो रेज भी रहे होंगे। आपने जिस दिन से ट्रीटमेंट स्टार्ट की और 1 month, बट अनफॉर्चुनेटली वी डू नॉट हैव डेस्मोग्लाइन 3 levels, so mainly we rely on our clinical acumen that this is a recalcitrant disease. But in our clinical setup, what we come across or the challenge which we face is the lowering of the steroid. Every time we lower it to 30 to 40 milligram, they have a disease relapse. Yes, it was. Sorry, next slide is steroid. Now this is the inclusion criteria. Patient of all ages, both gender, presenting with recalcitrant hemorrhages. All those who are not responding to 2 milligram for the induction, or all those patients who had disease relapse when their dose was lowered to 30 to 40 milligram, and this relapse was not once, more than 2 or 3 times. And they had this steroid dependence. Every time you lower their steroids, they have a relapse. So that was the criteria whereby we employed this rituximab. And the exclusion criteria are definitely newly diagnosed cases. We do not use rituximab, this low dose, severe cardiac disease, liver or renal disorder, active infection, history of cancer and pregnancy. So baseline पे हम ये सारी चीजें करते हैं, ये सारी जो protocols है, liver function and all these. What is important when you are giving rituximab is the tuberculosis screening, because we have tuberculosis rampant in our practice. So we chalk down all the methodologies, the relevant information and findings. So these are the results. I would like you people to concentrate on this. This first patient, which was 22 years old, he had previously DCP, solometrol pulses and everything, 40 milligram of steroid, VD, azathioprine, and he had number of admissions. This particular gentleman had more than 20 admissions, because every time his disease was relapsing again and again, and this is where we gave him the rituximab and his steroid. He was able to lower his dose to 20 milligram OD, and he had persistent remission 6 months on the follow-up. These are the other patients, because as I have told you, we normally give them, because if we come across these patients, all of these patients except two who bought the rituximab, rest of the patients, we arrange their rituximab from the sales Sahulat program, whereby the drug was given free of cost. So these are the same. If you look at them, they have number of admissions. We had most of these patients, almost all of them had solometrol pulses besides steroid and the azathioprine along with cyclophosphamide, and their disease was not relapsing. And if you see, most of them at the follow-up, they had minimal amount of the steroids and they were in complete remission at 6 months follow-up. So these are the number of cases. Complete remission was achieved on treatment in 8 patients. 1 patient had complete remission off treatment. That was, he was taking no treatment at all. And partial remission on treatment was observed in 2 patients, and partial remission off treatment was not seen. So total of 11 cases that we treated with the rituximab. Now these are the few pictures. This is the first gentleman that I told you that he had solometrol and cyclophosphamide, and his disease was not responding to the treatment. He was okay with rituximab. This is another patient. Yet another patient. So in conclusion, it is effective in induction of remission, in recalcitrant pancreatitis, and it decreases the severity of disease. dose of steroids and immunosuppressant, and the number of admissions. This is very important, and it has very socio-economic, because these people, they do not do any jobs, so once they are okay, they can go back to their jobs also. Now, what are the recommendations? That because it is a very high cost drug, if you are giving the protocols or the regimens which are mentioned in the literature, that would be not cost effective in our setting. So it is that the low dose, that is 500 milligram, is effective, and it is very important that we need to do a randomized control trial in our setting, whereby we compare the low dose rituximab with cyclophosphamide pulses, which we employ for the recalcitrant disease. And one very important finding or the outcome is that we need to do advocacy for rituximab in the pemphigus patient, because rheumatoid arthritis patient get it free of cost from Baitul Mal, because we do not have done advocacy. So normally at Baitul Mal do not give these drugs free of cost to our patients. So we need to do advocacy for pemphigus patients. So this is my hospital where I work. It's the Bolton block, and thank you very much for your attention.
Thank you so much, sir. Now I would like to request Dr. Rabia Mahmood to come up on stage and deliver a talk on nanometrics on a novel treatment for hemorrhage.